Good evening, everybody. Uh,
Hello. Good evening,
yeah,
sir. So
good
we're
evening.
just waiting for Dr. Anuj Grover sir to join, and then we'll start with the
Sure,
proceedings.
sure, 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 sure.
Hello.
Uh, Hello.
Hello.
So good evening, everyone.
Correct
I
છે
welcome you.
જોતા નહીં બરાબર જોઈન તો છે તું નથી તે
So good evening, everyone. I welcome you on the behalf of West Zone Noel session, yet another session for this week. So we'll be having two sessions this week. We couldn't conduct the last week session because of the Ahmedabad tragedy that has happened. So this week, on the Tuesday, we plan to have a case discussion, and on the Thursday, we'll be having a panel discussion. So for this session, I would like to invite Dr. Anuj Grover, sir. He'll be the moderator for this session. Sir is a senior consultant neonatologist at Setu Newborn Care Center, Ahmedabad. I welcome you, sir, for this session, and over to you, sir. You may introduce the presenter as well as the experts for the session today.
Good evening, everyone. Thank you very much, Dr. Gunjan. Pleasure to join everyone in the NOEL. I hope I'm audible.
Yes, sir, you're audible.
Okay. So we're going to have two case discussions today, and both related to two babies with interesting issues, and we have two experts in the field of neonatology who really need no introduction. Dr. Tushar Parikh, senior consultant neonatologist from KEM Pune, and Professor Dipen Patel, dear friend from Pramukh Swami Medical College, Karamsad. I welcome both of you.
Thank you.
Thank you, sir.
I hope we have very good interactive presentations from our participants. Without wasting much time, can I ask Dhwani, who is the first presenter, to start? She's a neonatal fellow at Setu Ahmedabad. And over to you, Dhwani.
Good evening, everyone. I'm Dr. Dhwani Patel. I am currently doing my fellowship in Setu Newborn Care Center.
Go ahead, Dr. Dhwani, you're audible.
Just a second. So I'll be sharing my screen. So my case is of preterm with Hailey syndrome. Brief history: Baby A, she was born at 25 week 2 days of gestation via vaginal delivery. Her birth weight was 600 grams. Baby was admitted in view of extreme prematurity and respiratory support. Developed pneumothorax on day 2 of life and managed for the same. Currently, the baby's postmenstrual age is 30 week 2 days, with current weight being 720 grams on heated humidified high flow nasal cannula, and the full feeds via an infant feeding tube. I would like to start my history from the antenatal part. Pregnancy was conceived by a 29-year-old primi gravida mother with natural conception. Mother had no history of any prior illnesses. Dating scan was performed, which was normal, and supplements were taken by the mother. In second trimester, iron and folic acid supplements were taken by the mother, and anomaly scan was normal. Delivery details. At 25 weeks, mother had pre-labor rupture of membranes. She was admitted to hospital and received antenatal steroids. Betamethasone, first dose administered at admission, and second dose prior to the delivery, 5 hours prior to the delivery, and she also received magnesium sulfate. Baby was born via vaginal delivery. Birth history. Baby was not vigorous at birth, so initial steps were performed. Delayed cord clamping could not be performed, and was received in sterile polythene plastic wrap. Baby cried after 30 seconds of intermittent positive pressure ventilation. Baby had respiratory distress. The Silverman-Anderson score was 5 by 10, and PEEP was delivered via T-piece, and baby was transferred to the unit in ambulance. The events. On day 1, baby was kept on CPAP initially. The FiO2 requirement was 60%. The respiratory distress increased, and Silverman-Anderson score was 8 by 10. So baby was intubated, and initial ventilatory settings on patient-triggered ventilation mode were PIP of 21, PEEP 5, and FiO2 55%. First dose of surfactant was administered at 1.5 hours of life. Bovine extract surfactant was given. This was the X-ray of first day. Parenteral nutrition was initiated at admission, and trophic feeds were initiated on day 1 of life. Gradually, the feeds were increased as tolerated well by the baby. Blood culture was performed, and antibiotics were started as per the unit protocol. With IP of 19 and PEEP of 5. The second dose of surfactant was administered on second day, and the ventilatory settings were gradually tapered. The baby had, after few hours, the baby had episodes of desaturation. The FiO2 requirement was increased up to 70%, and distress was increased. On examination, the air entry was decreased over the right side. After checking on trans-illumination was checked with cold light, which revealed right-sided pneumothorax, and it was confirmed by lung USG. Immediately, the intercostal drainage tube was inserted, and it was confirmed by X-ray.
Dr. Dhani, your voice is breaking.
Blood gas was performed, which revealed pH of 7.
Vani, your voice is breaking up.
CO2 58 mmHg, PO2 of 45 mmHg, bicarbonate was 30.
You're back on, Dhoni.
Yeah, okay, thanks. Is my screen visible?
No.
Not yet.
Just a second. Is it okay, sir?
Still can't see the
Am I audible
slides.
now, sir?
Now it's okay.
Okay, okay, sir. Um, so the inotrope was started in view of perfusion concerns. The blood gas was repeated after 12 hours, which revealed pH of 7.31. PCO2 was 42 mmHg and PO2 was 48 mmHg. Bicarbonate was 19 millimole per liter and base excess was minus 3.7. Lactate was 2. Gradually, the ventilatory settings were tapered. The intercostal drainage tube was clamped on day 5 of life, and there were no column movements present. It was negative. The intercostal drainage tube moved on day 6 of life. Then baby was left 8th day of life, and then on hepatic hydrosol cannula on 14th day of life, and C 4 liters per and 21%. The nutrition part, the feeds were gradually increased as tolerated well by the baby, and full feeds were reached on day 7 of. Supplements were added 9th day onwards. In cardiovascular part, the 2D echo was performed after 24 hours, which revealed tiny PDA and which was not hemodynamically significant. Echo was repeated after 48 hours and which revealed closure of the duct. Sepsis workup. 2 sepsis screens were performed and they revealed the negative findings. Serial CRP readings were 5.9 milligram per liter and 1.21 milligrams per liter. Blood culture report was negative and antibiotics stopped 6 of life. On examination, the baby is lying in supine position and has mild respiratory distress, and the baby has HFNC support. Environment and vitals. The baby is nursed under radiant warmer with servo controlled mode with set temperature of 36.5 degrees Celsius, heater output being 25%. The skin probe is attached to the right hypochondrium. Suction probe attached to the lower limb and pulse oximeter showing heart rate with 134 per minute and saturation 95%. Baby is currently on HHFNC 4 liters per minute and to 21% with the cannula covering 50% of the net and respiratory rate is 60%. Is orogastric geometry part. So in this graph, I've used the Fenton's chart. The blue dots are showing the centiles at birth, and red dots are current weight, head circumference, and length. So the observed weight is 720 grams against the expected of 1.1 kilo, 1100 grams, which is less than 10 centile. Head circumference is 26 centimeters against the expected of 28, which is also less than 10 centile. And the length is 33.5 centimeters against expected of 38 centimeters less than centile. On head-to-toe examination, the head is normal in shape, with entire fontanelle open, while one eyes are normal and retinal focus. Ears are normal externally. Orogastric tube is present in mouth
Dr.
and there is no
Dhani,
cleft lip on it.
Dr. Dhani, your
Lower
slides are not moving.
limbs are normal and spine is normal. Hips are stable and on genital exam. Yes.
Dr. Dhani, you switch off your video so that there will be bandwidth saved for the slides. Slides are not moving and your voice is not coming clear.
Yes.
Uh,
Can you reshare your screen, Dhani?
Yes, sir.
you can complete the case. You can share the slides. You can switch off the video and you can talk and complete the slides and the
Okay.
presentation. Because your voice is
Okay, sir.
breaking. That's the thing.
Yes, sir. Am I audible, sir?
Yes, you are audible. Your slides is not yet visible.
Yes, sir. Just a second. Are the slides visible, sir?
Yes.
Yeah.
Um, so in systemic examination, respiratory system, on inspection, the chest is normal in shape. Mild tachypnea
I
is
think,
present
Dhwani,
with.
you might have to go back a few slides because your voice was not heard and the slides have moved on quite a bit.
Okay, sir.
Go back a couple of slides, I think. From the start with the examination, yeah.
Yeah, here I
Okay.
think.
So in examination, the baby is lying in supine position as mild respiratory distress, and the baby is on currently HHFNC support. Environment and vitals. The baby is nursed under radiant format with servo control mode. Set temperature is 36.5 degrees Celsius and the heater output is 25%. The skin probe is attached to the right hypochondrium. Saturation probe is attached to right lower limb with pulse oximetry showing heart rate of 134 per minute and saturation is 95%. HHF
There is too much of audio interruption. I think audio is not clear.
and effort is 21%.
So we'll go through the slides quickly because we can't hear anything. So let us speak whatever we are able to hear and we'll read through the slides. Yeah, I think we'll have to go through this. Otherwise, we won't be able to complete the case. Dr. Dhani, your voice is too much breaking. We can't hear anything. Just see if anything at your end on an internet connection. Otherwise, just run your slides. Dr. Dhwani, you're there?
I think she's trying to log out and log in from another computer.
Okay. Yeah.
There seems to be a lot of voice issues, unfortunately.
Yeah. We'll wait for maybe 2 minutes, 1 or 2 minutes.
Yeah.
Hello.
Hello, Dhwani.
Dhwani?
Sir, I think we can
Hello.
give a chance to the second person. So meanwhile, Dhwani joins, we can ask her a separate question, I think. I think that is the best.
I think that is better idea. Till she reconnects, second case can be started.
Yeah, I think that's a good idea. I think we have a discussion then together later. Dr. Sachin Manor,
I think that's fair.
Yes, sir.
yeah.
Sir,
Sachin, you
am I
want to
audible?
share? Yeah, you're audible. Please share your slides and then you can do the presentation and then we'll take the questions together at the end, I think. Is that
Yes.
okay, Dr. Dipin and Dr. Anush?
Yeah,
Yes,
that's fine, I think.
Yeah.
So
Yeah.
Sachin, Dr.
Yes.
Sachin
Yes,
can
sir.
present
Sir,
the
I have
second.
sent a request to share the screen.
Yeah.
Okay, your slides are visible.
Yes, sir. Am I audible and my screen is visible, sir?
Yes.
Yeah, sounds fine.
Yes. Sir, good evening, everyone. I am Dr. Sachin Manohar, neonatal fellow from KEM Hospital, Pune. I'll be presenting case based on pulmonary interstitial emphysema. Coming to the introduction, baby of Gardi twin 1. It's a male infant born at 28 weeks of gestational age with birth weight of 1,110 grams by emergency caesarean section in view of preterm labor. As of 12 June 2025, the baby was 26 days old with corrected age of 31 plus 4 weeker, admitted with respiratory distress on mechanical ventilation. Coming to antenatal history, the baby is born to 23 years old primary gravitar mother. This is an in vitro fertilization diamniotic twin pregnancy. The rest of the antenatal history is uneventful. Mother had received 2 doses of betamethasone acetate 48 hours and 24 hours prior to delivery, respectively. Mother had a history of urosepsis in perinatal period, which subsequently led to preterm labor. Since a trial of tocolysis failed, emergency caesarean section was done on 18th May 2025 at 28 weeks of gestational age. The baby was born. The baby was born on 18th May 2025 at 12:20 p.m. Cried immediately after birth and went into apnea, for which resuscitation was required. Baby received 1 cycle of positive pressure ventilation for 30 seconds. Baby was shifted to NICU on T-piece resuscitator with a peak inspiratory pressure of 15 and positive and expiratory pressure of 5 and FiO2 of 30%. At NICU, baby was intubated in view of progressive respiratory distress with Silverman-Anderson scoring of 7 by 10, requiring positive and expiratory pressure of 6 centimeter and FiO2 of 40%. A chest X-ray was done, which showed grade 2 RDS. Endotracheal surfactant was administered. That was Survanta at 100 mg per kg at 1 hour of life and was supported with mechanical ventilation, on which he showed clinical improvement. On day 3, baby had sudden increase in pressure and FiO2 requirement. Clinically, there was an asymmetrical chest movement with decreased air entry on the left side. Trans-simulation test was done, which revealed pneumothorax on left side. Chest X-ray confirmed the finding. Needle thoracentesis was done immediately with a butterfly needle at left side, second intercostal space in mid-clavicular line. And intercostal drainage was spaced. As you can see here, there is a huge pneumothorax on the as you can see, there is a huge pneumothorax on the left side, which was on day 3 of life. And there is a tracheal shift to the right side. On day 6, respiratory distress increased with progressive increase in FiO2 requirement. Chest X-ray was done, which had features of pulmonary interstitial emphysema, such as multiple small cystic radiolucents with bilateral hyperinflation, which is but right more than left. As you can see here, small cystic lesions which are radiolucent extending from the hilum to the periphery. As ventilatory settings were adjusted and such as peak inspiratory pressure, positive and expiratory pressure and inspiratory time were decreased. Follow-up X-ray was done and which showed there was a left lower lobe collapse. With as you can see, there is crowding of lips with the collapse on the left side and deterioration of pulmonary interstitial emphysema as the size and the number of multiple cystic radiolucents findings have increased and it is extending from the hilum to the peripheries. Ventilation was escalated to high frequency oscillatory ventilation with a map with mean airway pressure of 12 and FiO2 of 60%. Minimal section was done and chest physiotherapy was avoided. And on day 14, there was a deterioration as FiO2 requirement on high frequency oscillatory ventilation had increased. Hence, chest X-ray was done, which showed persistent pulmonary interstitial emphysema with increasing size and size of the cystic lesions and number of cystic lesions. Actually, map was main airway pressure was tapered to 9 gradually. On day 19, there was some improvement as FiO2 requirement had reduced and the X-ray showed decrease in the cystic lesions as well as number of lesions and size. As we can see on the right side, there are very few. They are not completely improved, but there are some improvement all over the lung field. By day 24, ventilation was tapered to conventional ventilation on which baby remained stable. X-ray showed resolution of pulmonary interstitial emphysema with collapse on the right upper lobe. Suspected early onset of sepsis. As there was history of urosepsis in mother, sepsis screen along with blood culture was sent. Broad spectrum antibiotics were started as per unit protocols. Sepsis screen was negative and blood culture was sterile. Hence, antibiotics were given for 5 days and stopped. Hemodynamic significant PDA, persistent ductus arteriosus. On day 2, there was an increased FiO2 requirement. Functional echo revealed persistent ductus arteriosus of size 2.2 mm. Paracetamol was given for 3 days of total 12 doses. Coming to nutrition, total parenteral nutrition was started on day 1 of life and minimal enteral nutrition was started on day 2 with 10 ml per kg per day, gradually graded up by 20 ml per kg per day, and full feeds were achieved by day 7 of life. Human milk fortifiers were added on day 8. Currently, baby is on full OGT feeds, that is with a TFR of 180 ml per kg per day, and it's tolerating well. Coming to examination findings on day 24, baby of Gardi 1, a preterm baby with respiratory distress is receiving ventilatory care. Baby is being nursed under radiant formula with set temperature of 36.5 degrees Celsius and measured 36.4 degrees Celsius with heater output of 25%. Baby is lying in supine under a warmer with a cap ET tube fixed at 7 and a length of 2 cm from the mouth to the adapter. Nasogastric tube fixed at 18, nasogastric tube size of 6 fixed at 18 centimeters. Pulse oximeter is placed at right hand and temperature probe is placed in right hypochondric region. Currently, baby is on synchronized intermediate mandatory ventilation mode with pressure of peak inspiratory pressure of 18 and a positive and expected pressure of 5 and effective requirement of 30, and delivering tidal volume of 5 ml per kg. Humidifying chamber at 37 degrees Celsius with adequate level of water with the minimal condensation noted on the expiratory. Coming to vitals, pulse rate was 146 beats per minute, regular rhythmic, and all peripheral pulses and all four limbs were well fed. Respiratory rate was 48 beat per minute. Color baby's color was pink. Capillary filling time was less than 3 seconds. Blood pressure, which was measured at right upper limb, was 58 by 38, with a mean blood pressure of 48, which is at 50th centile. And set temperature was 36.5 degrees Celsius and measured at 36.4 degrees Celsius. Saturation was 90%, 95% on FiO2 of 30%. Coming to examination, anthropometry weight at birth was 1,110 grams, which was at 50th centile, and present weight is 1,209 grams, which is at 10th centile. Length is 36 centimeter, which is between 10th to 50th centile, and present length is 39.5 centimeter, which is at 10 to 50th centile. Head circumference is 26 centimeter, that's between 50th to 90th centiles. Present 28 centimeters, that is 10 to 50th centiles. And head to toe examination, nothing significant. System examination, baby is intubated with a tube of urotracheal tube of size 3, fixed rate number 7 centimeters, and a length of 2 centimeters from the mouth to the adapter. Baby is being ventilated on synchronized intermittent mandatory ventilation mode. The pressure of 18 with the peak inspiratory pressure of 18 and positive and expected pressure of 5 with FiO2 requirement of 30. Delivering a tidal volume of 5 ml per kg, humidifying chamber at 37 degrees Celsius with adequate level of water with minimal condensation noted in the expiratory liquid. On these settings, baby is comfortable with adequate chest rise and respiratory rate of 48 per minute and saturation of 95% at right upper limb. Other systemic examination insignificant as S1 S2 were heard, no murmur, per abdomen it was soft, round tender, no organomegaly, and both sounds were well heard. CNS, babies under sedation with injection filter. Coming to diagnosis, it's a very preterm, 28 weeker with very low birth weight, 1,110 grams, male infant, RDS with left pneumothorax and right pulmonary interstitial emphysema with suspected early onset of sepsis and hemodynamic significant PD. Coming to the theoretical part of the pulmonary interstitial emphysema, it is nothing but a collection of air in the tissue of peribronchiovascular sheath. It occurs in extremely preterm infants with RDS or pneumonia who are mechanically ventilated. Transpulmonary pressure that exceeds the tensile strength of the non-cartilaginous terminal airways and alveolar sacs can damage the respiratory epithelium. Loss of epithelial integrity permits air entry into the interstitium, causing pulmonary interstitial emphysema. Coming to the pathophysiology of the disease, in preterm babies, there is more perivascular connective tissue, which is less dissectable than in term babies. This results in air trapping in the perivascular space, leading to pulmonary interstitial emphysema. The interstitial air can be localized or spread to involve significant portion of one or both lungs. It can dissect it towards hilum and towards pleural surface via adventitial connective tissue surrounding the lymphatics and pulmonary vessels. This can compromise lymphatic drainage and pulmonary blood flow. Pulmonary interstitial emphysema alters pulmonary mechanism by decreasing compliance, increasing residual volume, and dead space, causing ventilation perfusion mismatch. Coming to diagnosis, pulmonary interstitial emphysema frequently develops within 48 hours of after birth. It may be accompanied by hypotension, bradycardia, hypercarbia, hypoxia, and acidosis. Pulmonary interstitial emphysema has two characteristic features in on chest X-ray, which is linear lucencies radiating from the lung hilum. Occasionally, last cyst-like blebs give the appearance of pneumothorax. Coming to the treatment part, attempt to decrease mean airway pressure by lowering peak inspiratory pressure, positive and expiratory pressure, and inspiratory time. high frequency ventilation can be utilized in infants with pulmonary interstitial emphysema to avoid large tidal volume. Unilateral pulmonary interstitial emphysema may improve if infant is positioned with the affected lung dependent. Endotracheal sectioning and manual positive pressure ventilation should be minimized. Several localized severe localized pulmonary interstitial emphysema that has failed to improve on conventional conservative management may require collapse of the affected lung by selective bronchial intubation or occlusion or rarely surgical resection. Complications of pulmonary interstitial emphysema may precede more severe complications such as pneumothorax, pneumopericardium, or air embolism. Thank you.
Very good. You can stop sharing your slides.
Yes, sir.
Yeah. Dr. Anuj, you want to ask any question? Dr. Dhwani, you have your slides ready?
Maybe we can ask some questions to Sachin.
Yeah. So, Sachin, so basically this baby had a pneumothorax on the left side, and then right side the lung had pulmonary interstitial emphysema. So can you tell what are the risk factors for development of pulmonary interstitial emphysema and pneumothorax for the specifically pulmonary interstitial emphysema? What are the risk factors? Antenatal risk factors, delivery, and later. So what will be the risk factors for development of PI?
So extreme prematurity, that is less than 28 weeks, or
Very good.
extreme low birth weight, or babies having severe RDS, and babies on mechanical ventilation with high peak inspiratory pressures, pulmonary positive and expiratory pressures, or high inspiratory times.
Yeah.
And surfactant on single lung, accidental administration of surfactant to the single lung. And
Okay. Yeah. Anything more? Infection?
yes, infection like pneumonia.
And what about antenatal steroids?
Antenatal steroids helps in decreasing the risk for the RDS, which is eventually to pulmonary interstitial emphysema.
Right. So again, basically, I mean, the case part presentation was, I think, good. Basically, when it is bedside, it is different. But when we talk about pulmonary interstitial emphysema or pneumothorax, it's about use of antenatal steroids will reduce it. Then what type of resuscitation will help it? Infections, they increase the risk. So, okay.
Yes,
So,
yes.
yeah, if it is, yeah. And then in the delivery room, any intervention that is likely to increase the risk of a pulmonary interstitial emphysema or pneumothorax?
Yes,
So,
sir. Unmonitored and high pressures during resuscitation, uh, uh, high pressures during you doing resuscitation via AMBU masks.
right. So,
And
yeah. So again, if you look at the coin trial, again, what happens in the delivery room if you give high CPAP pressures versus surfactant. So it was again surfactant versus CPAP in the delivery room. Now, if you give CPAP in the delivery room, you decrease the need for surfactant and
yes,
decrease the need for mechanical ventilation, but it comes at a cost of slightly increased pneumothorax. But then
yes,
there was argument that they were using very high CPAP pressures. So again, very
yes,
important that CPAP we continue in the delivery room, making sure that we don't use very high CPAP
yes,
pressures. There was
yes,
in between fashion of using sustained inflation, where you give
yes,
15 to 30, 15 seconds of 15 to 30 centimeter of high continued pressure. Again, that has gone out of favor now because of increased mortality, and that is again leads to increased air leaks. So that is one important aspect. What about T-piece resuscitator versus bag and mask?
So TPS decreases the frequency of decreases the risk of pneumothorax, because as we give controlled peak inspiratory pressure as well as positive and expiratory pressures,
Correct.
and
So
as well
again,
as we can tighter SFO.
right. And uniform lung inflation plus you have control over both. So
Yes.
peak pressure as well as positive and expiratory pressure.
Yes.
And what about ventilator parameters that will determine that will reduce the risk of pulmonary interstitial emphysema? Any type
So
of ventilator?
as we administer the surfactant, after administration of surfactant, as the lung compliance improve, it is advised that we have to taper down the positive peak inspiratory pressure as well as positive and expiratory pressure, so that it decreases the risk of barotrauma, which leads to pneumothorax and pulmonary interstitial emphysema.
So amongst the two, PIP and positive end expiratory pressure, which is more kind of damaging?
So, positive and expiratory pressures.
Is it so? So
Sorry,
at
sir.
what point in time? So you just said, na? So at the peak of the pressure, the air kind of gives way, the
Yes.
epithelium gives way, and the air leaks into the vascular or peribronchial tissue,
Yes.
and
Yes.
it's spread. So it is a PIP, peak inspiratory pressure is more damaging as compared to PWP.
Yes.
But of course, both pressures as such, they contributing to development of pulmonary interstitial emphysema. So you make an attempt to reduce PIP as well as PWP. So that is one thing. So what is more damaging, low I time or high I time?
Sir, high I times.
Correct. So high I time will again cause more pulmonary interstitial emphysema. What about rates? Low rate or high rate?
So, low rate decreases the risk of pulmonary interstitial.
So as such, the rate has not been shown to have any effect as long as the I time is less. And because what happens is that, it is again depends on the I time. So if you want to reduce I time, sometimes you may have to go up on the rate to get adequate ventilation. So strategy will be to give less PIP, lower PWP, lower I time, if required higher rates to achieve proper ventilation, and if required higher FiO2, because FiO2 will have not much of effect on development of pi. What about volume ventilation versus pressure ventilation?
Uh, Sir, volume mode of ventilation is better than pressure, as it decreases the risk of barotrauma.
Yeah, so technically, when the surfactant is administered or when there is a changing pulmonary mechanics, in that scenario, you will ensure that you will not cause, high volume pressure, high volume trauma to the lungs. So volume ventilation again is kind of preferable again, but here we have to remember, you have to be comfortable. Your unit has to be comfortable with the ventilator that you're using, because when you're using volume ventilation, you have to ensure that there is no air leak, and if air leak is there, it is factored in. Otherwise, ventilator may inadvertently give higher volumes. So it comes with that. But yes, volume ventilation kind of it will help you to reduce the chances of lung injury.
Yes.
The other than that,
Can I have one question?
yeah, please, Dr.
Sachin, I noticed that when you picked up the pneumothorax on day 3 on the trans elimination,
Yes, sir.
you waited for an X-ray before putting in the needle or the ICD. Why did you wait for the X-ray? This baby clearly on the X-ray, it looks like a massive pneumothorax with a medial signal shift. So what are the bedside ways you can detect a pneumothorax?
Sir, we can do a point of care ultrasonography, and
And
we
if your
will get
trans
that.
elimination and point of care ultrasound is already positive for pneumothorax, do you need
Yes.
to wait for an X-ray?
No, sir. We have done needle thoracentesis and waited for the X-rays.
Okay. Instead of needle, can you directly do an ICD, or do you want to always put a needle first?
Preferably needle thoracentesis to manage the immediate deterioration of the baby. As once the baby is stabilized, we can place the intercostal drainage because it takes some time to prepare it and put it.
So what are the advantages of the needle over the ICD?
So immediate response in baby with the improvement in heart rate and better
So if your
increase
baby is
in lung compliance.
hemodynamically compromised, then the first thing should be the needle, obviously, because
Yes.
you want to, if it's a tension pneumothorax, you don't want to wait till you prepare for an ICD. So you want to do a needle first and
Yes.
then put an ICD.
Yes.
But if the baby is in minimal oxygen and you're confirmed pneumothorax, then you may put an ICD as the
Yes.
initial one itself.
Yes.
Dr. Deepen, have you got any questions for Sachin?
Yes, I have a question, sir.
Please.
Regarding the antenatal surfactant, antenatal steroids, the mother received betamethasone, right?
Yes, sir.
So, can you elaborate detail when steroid may not work?
Sir, in when mother has a chorioamnitis,
Right. So chorioamnitis is probably, if it is confirmed, then it is a kind of a contraindication for steroid, isn't it?
yes.
Yeah. So what are other factors in which steroid may not work? So one factor is the type of steroid which we use, right?
Yes, sir.
So which is a better steroid in preventing complications in preterm newborn? It is a dexamethasone, isn't it? So
Yes, sir,
do you know any difference between dexamethasone and betamethasone?
Sir, dexamethasone we give 4 doses and betamethasone we give 2 doses at 24 hours apart.
Okay. So the guideline which was provided by Government of India, right, was in 2014. Are
Yes,
you aware of this guideline?
Yes.
Yeah. So what
Yes.
what salt we have available of betamethasone is betamethasone phosphate, right? But the ideal salt which is studied is betamethasone acetate and phosphate.
Yes.
So which is not available in our country. So the guideline says better to use dexamethasone phosphate, which is available, sodium phosphate, which is available in our country, which is more heat stable than
Yes.
the betamethasone phosphate, which is less heat stable and it has very short effect. So what
Yes.
happens is when you give betamethasone phosphate at 12-hour interval, right? So that would have a lesser effect in a baby as compared to dexamethasone, which you give at 6 hour apart at 6 hourly, right? So here
Yes.
the betamethasone was given at 12-hour interval, right? So probably that would also be a cause when the steroid may have a less effect as expected. So these are the factors which may add a complication, kind of increased morbidity in preterm newborn. Are you aware of any, who is the pioneer of antenatal steroid? Who started initial studies?
Sorry, sir.
Okay, so he was the Liggins, right? So he published in 1972 in Pediatrics about effect of steroids on premature labor in lambs, right? So what he noticed is, so there was lack of RDS, and survival of preterm lambs increased. So based on these initial studies on lambs, they found that the effect of antenatal steroid would be beneficial, and then further studies were done in humans, and that proved that it has improved outcome. So what are the advantages of using antenatal steroids? Already you know, I may not go in detail, isn't it?
Yes.
Some of the factors already Dr. Tushar sir has discussed. So I would like to elaborate in more detail about the what are the preventive factors for reduction in Ehrlich syndrome in newborns?
Yes, sir.
Yeah.
Early administration of surfactant.
Perfect.
As
So
soon as
this
we
is-
admit the,
yeah, good. Yeah.
as soon as we administer the surfactant, we as the immediately lung compliance starts improving. As the lung compliance starts improving, sir, we cannot keep the same pressures which were required prior to the surfactant admission. So I have to taper down the pressures, both peak inspiratory pressure as well as positive and expiratory pressure. So that
How will you decide? How
as the
will you
compliance
decide
improves.
to go down with the pressures?
Yes.
So when baby you have given surfactant, so
Yes, sir.
how will you go by tapering the pressures? Do you have any alternate strategy?
Yes, sir. We can put on volume guarantee mode, so it is a auto weaning.
Yes, so that would manage pressure, right? Because when volume
Yes.
appropriate volume is delivered, it would avoid
Yes.
delivering the higher pressure, and that would avoid damage to the lungs and would
Yes.
reduce the Ehrlich syndromes in newborns.
Yes.
What about the other complications of pneumothorax or PIE? So one is you mentioned, right? Increased respiratory support, right? So
Yes.
what other long-term or short-term complications that may arise of
Sir,
pneumothorax?
short-term complications are pneumopericardium, pneumomediastinum,
Okay,
which might lead to which leads to hemodynamic instability and decreased cardiac contractility.
great. So it would so the Ehrlich may further worsen, right? And
Yes.
may extend to other areas like pneumopericardium, pneumomediastinum, may also lead to pneumoperitoneum as well, and may also extend in neck, may lead to subcutaneous emphysema also. Other complication that may arise of Ehrlich is IVH. So do you know the pathophysiology, how IVH would occur in a case of Ehrlichs? Okay, I will explain. So what happens is whenever there is Ehrlich, there will be increased intrathoracic pressure. So that would lead to reduction in the venous flow to the thorax. So this will lead to increased cerebral pressure. Also, because of the reduction or reduced cardiac output, what would happen is there will be a change in the circulation, right, to the vital organs. So blood flow to brain would increase. And increased blood flow and the increased cerebral pressure will lead to IVH. So IVH may be a common complication in preterm newborns because they are already vulnerable for IVH. What are the other long-term problems are? They have studies have shown that if baby has pneumothorax, even survived without other complications, may have abnormal neurodevelopmental outcome. So that is also one of the complications. So you need to follow up regularly of the preterm newborns who develop pneumothorax. What are the clinical criteria of diagnosing pneumothorax? So one you said by X-ray, isn't it?
Yes, sir.
Immediately, also you said that sonography. Dhwani also said that sonography would help.
Yes.
Other clinical factors on bedside.
Sir,
We can ask a few
decrease.
questions to Dhwani as well.
Yes, yes.
The cases are very similar, both of them.
Yeah, Dhwani, you may answer this question.
Am I audible, sir? There increased entry on the side of the address will be later it will be increased. So these are the initial signs. Clinically, we can say that we can assume that the baby might be having pneumothorax.
Okay, so initial part I could not hear, but you rightly said that reduce our entry, right?
Yes.
By cold lamp examination, which will show
Yes. The
positive pulse
transamination will
illumination.
show.
Yes.
Yes.
Then increased respiratory requirement, isn't it?
Distress.
Clinically, on look at the chest, there will be less or reduced rise of the chest on the side affected, which had pneumothorax, in addition to X-ray and sonography, which is a gold standard to diagnose pneumothorax in adults. See, this question I ask because there are certain limitations of X-ray chest, isn't it? So if you look at the X-ray of a newborn who have a pneumothorax, is it possible that you may not pick up by X-ray? Sachin also can answer this question.
Yes, sir. Very rarely it's difficult to pick on chest X-ray.
When we will not pick on?
Sorry, sir, I didn't get your question.
When we will not pick pneumothorax on X-ray chest?
Sir, posterior part of the lung is involved.
Okay, so when a pneumothorax is there or anteriorly or maybe a posteriorly, maybe mostly it is anteriorly, right? Because air goes up. So
Yes.
anterior pneumothorax may not be picked up, which is of mild variety, isn't it? So
Yes.
in adults, what they say is the CT scan of the chest is the gold standard for
Yes.
picking the pneumothorax. But in newborn, what is the sensitivity and specificity by looking at the X-ray to find out pneumothorax? So X-ray has less sensitivity and specificity, right? A sensitivity would be around 80% and specificity is around 96%. But in comparison to X-ray, which is a better modality, we can say in current era.
Sir, USG chest.
Yes. So, but what is the limitation of USG chest?
Sir, it's not available in all levels of NICU.
Right. So it is not available in majority. Second thing is it requires some expertise, some training, isn't it? But not kind of extensive training. It needs
Yes.
expertise to do ultrasonography to pick up pneumothorax. But if one person is expert in identifying pneumothorax by ultrasonography, what is the sensitivity and specificity? So it is almost 98 and 99%. So you can understand there is a huge difference of sensitivity and specificity. So that's why sir has asked you, what is the immediate action you would take? Would you do X-ray or you would do intervention, right? So Anuj sir asked this question. So that's why if you are expert in ultrasonography, better not to go for X-ray and you intervene immediately.
Yes, sir.
I think I would ask other questions later. Over to you, Tushar sir, if you want to ask some other questions.
Yeah. So maybe now I'll ask Dhwani because she was on this thing. So Dr. Dhwani, this baby developed pneumothorax after the second dose of surfactant.
Yes, sir.
So yeah. So you said first dose of surfactant was given at 1.5 hours, and the second dose was given on second day. So how much should be the like? When do you decide about second dose of surfactant?
Uh, if the FiO2 requirement is still more 30% or more than that, after 6 hours of the first dose of surfactant, sir.
So is it only FiO2 or is there anything more to that?
Sir, if the distress is not relieved.
Yeah, so sometime what happens if you're using very high pressures, you may compensate FiO2 by giving high pressures, So mean airway pressure of more than 7.5 also is sometimes considered. Plus you can do a lung ultrasonography and lung ultrasound score of 8 or more, around 6 to 8 hours also can be an indication to give second dose of surfactant. Okay, so as you rightly pointed out, second dose we can consider after 5 to 6 hours if the baby continues to require oxygen more than 30%, or if the baby continues to require mean airway pressure more than 7.5, 7 or 7.5, or if the lung ultrasound score is more than 8 around that time. What is the role of surfactant in prevention of pneumothorax? So, if you consider synthetic surfactant versus artificial surfactant, which one will reduce pneumothorax?
Uh,
Studies
the
have shown that one surfactant reduces pneumothorax compared to the other.
the Synthetics, sir.
Will reduce or it will increase?
Tushar sir, you said synthetic versus artificial. Did you mean the natural versus?
Sorry, natural versus artificial. Did I say that? Sorry. Natural versus artificial. So which one will reduce risk for pneumothorax?
The natural surfactant would reduce the risk of pneumothorax, sir.
How does it reduce? What is different between the two? Which will help to reduce the risk of pneumothorax?
Uh,
So what you said is right. The Cochrane review says so that if you
it,
use natural
it
surfactant, the risk
acts
is less.
faster and
So what is the difference between the two surfactant?
it acts
Yeah, can't hear you actually. So basically, a natural surfactant is
faster. They are derived from the animal lungs, which contains the proteins, surfactant protein
yeah. So which
B and C,
so what is the role of B and C protein?
and
And
they are effective for the surfactant. Production.
so what is the role of surfactant protein A and D, and what is the role of surfactant protein B and C?
They are faster in acting, sir.
Faster in acting, as in what is the action that we're talking? We want to know the action basically
The
of
natural
surfactant.
surfactants are faster.
So okay, basically the
Sir, they are
natural.
important for the surfactant production.
I think your voice is too much breaking. Anyway, I'll explain. So basically, natural surfactant has got surfactant proteins which helps for its adsorption. The spread of the lipid surfactant, spread of the surfactant, the lipid compartment or the lipid component is known to uh,
Uh,
so, so the lipid part basically helps to basically the lipid is the one which reduces the surface tension, and your surfactant protein will help to spread it over the alveoli. So therefore, the natural surfactant will reduce the risk of pneumothorax. So previously we used to get sulfosylyl palmitate and artificial surfactants, and those surfactants did not reduce the risk of pneumothorax, or as compared to natural ones, they were little inferior. And the reason being surfactant proteins which helps to spread it. So surfactant protein A and D will help which are adsorbents, and surfactant protein B and C. What is the role, Sachin or Dhani? What is the role of surfactant protein B and C?
Sir, they are important for the spread of surfactant.
And what about A and uh, yeah? So all proteins have the same function.
No, sir. The B and C have they are important for the spread of the surfactant, and A surfactant A and D, they are important for the alveoli too, and they reduce the surface tension, and that's why the properties of surfactant, they can regulate the synthesis.
Okay. Uh, yeah. So basically, they have anti-inflammatory or anti-infection properties also. And so surfactant, little their roles are different, but most important role is basically they will have is a spread of surfactant on the alveoli. And since they are lacking in the artificial one, you will have increase in the risk of pneumothorax. Now, many times you see, like what I see is that doctors calling it as spontaneous pneumothorax. So, what is spontaneous pneumothorax? Is this a spontaneous pneumothorax in the baby? Dr. Dhwani or Dr. Sachin? Can you call this
Um,
spontaneous pneumothorax? Or is what will you call? What is spontaneous pneumothorax? Is it different than this?
Yes, sir. Without any predisposing factors, babies or babies vitally stable on movement without any ventilator support.
So as the name suggests, without any reason, there is no infection, there is no lung disease, there is no positive pressure ventilation, and still the baby develops pneumothorax. So what is the underlying pathology believed to be in such a case?
Uh, Delay in tapering the pressures during the
No, I'm saying spontaneous pneumothorax.
presence of bloods.
So it is
you're
believed that the
entering
underlying lung may be little high. Yeah.
the hyperinflation, sir. The compliance improves faster. So
Yeah,
if the
somebody has
volume is
written rupture of bleb. So subpleural bleb sometimes they're saying, but it is believed that the underlying lung may be some amount of hypoplasia may be there, and underlying lung may be little hypoplastic, and then you may need to screen such babies for kidneys basically. So spontaneous pneumothorax can have sometimes the cystic diseases in the other organs, or sometimes it can have a underlying renal issue, renal disease also, and it may be because of the partial or hypoplasia of the lung. All right. Um, uh, Now, what is nitrogen washout for treatment for pneumothorax?
Breathe.
Sachin?
Sir, giving a high FiO2 leads to the increased accumulation of fractional FiO2 and decrease in washout of nitrogen.
So, what is that? Where is the nitrogen?
Sir, if it's air itself, sir, if you are giving 40% FiO2, the remaining 60% is nitrogen.
Is it in the ventilator? But what is washout? Nitrogen washout. So you're there, but not correct, not accurate.
But giving FiO2 of 100%.
Correct. So where are you removing nitrogen from then? So I think what you said is right. So in good old days, we used to give such a babies 100% oxygen, not like a 25 weeker and 29 weeker. For a full-time baby who's developing pneumothorax, you give 100% oxygen, and the air which has gone into the pneumothorax, because it is a air, it has got almost 78% nitrogen. And so when you give 100% oxygen, the nitrogen from this pneumothorax kind of is absorbed into the blood, or it's transferred into the alveoli and goes out through the air. So it is believed that giving 100% oxygen in babies with spontaneous or in the babies with pneumothorax will kind of remove the nitrogen from the air which is there in the pneumothorax and reduce the size of pneumothorax. So this was, but now we will not following it so much. But again, this is important that such a thing is there and people used to follow it. All right. Uh, Dr. Anuj, Dr. Dipen.
Yes.
One
Ah,
question I had, sorry, Sachin, in your case, the PIE changes were pretty more uh, visible on the right side. So why do you think there was a differential PIE, one lung worse than the other?
as there can be accidental administration of surfactant to the unilateral lung, that is in our case right side.
Yeah, that is one of the most common reasons why you will have a differential one, because and it usually happens on the right side because of the tube is in the right main bronchus. The majority of the surfactant will end up on that side, and so you may have an area of hyper expansion on the right side, and the left lung will not expand that much. So you have kind of a collapse area on the left side and hyper expansibility on the right side. I don't know whether that was the case with yours, maybe or not, but that is one of the reasons why you would have a differential PIE.
Okay.
Dhwani? Dhwani, are you listening? Hello? Hello?
I think she has poor net connection.
Yeah.
Okay, so Deepan sir, you have any questions?
I may ask Dr. Sachin, are you aware of RDS next guideline? RDS, respiratory distress syndrome, next. So that is RDS, Neonatal Expert Task Force Committee, right?
Yes.
So
Yes.
that was for treatment of RDS, and they have provided a table called as RDS indication of surfactant table. Are you aware of that table? It
No,
has
sir.
4 components. Right. So it
I will be the-
decides when will you give surfactant, isn't it? So they have included Downey score here in this guideline, whether baby was intubated or not, what was the FiO2 need, and what is the blood gas. So any 3 of these 4 criteria meets, then baby can be given surfactant, right? So are you aware of any difference between Downey score and the Silverman-Anderson score, which we do in preterm newborn?
Silverman Anderson score is done in preterm, sir.
Right. So what about Downey score?
So it's done in term babies.
Right, but here you can see in RDS next consensus guideline, they have provided Downey score, not Silverman and Anderson score. Any reason? Because Downey score is a comprehensive score, isn't it? Because it has
Yes,
how many
sir.
components?
So it has respiratory component, respirator.
Right. Just elaborate.
Total 5, sir.
Pardon?
So baby has Downey score has 5 components,
Yeah.
but SAS score has just
Yes.
increase in the just the retractions as well and grunting. That's about three components.
Perfect. So Downey score has 5 components like respiratory rate, retractions,
Yes.
then cyanosis, so need of oxygen,
and air entry.
then what?
Cyanosis,
Air
air
entry.
entry, grunting,
Yes,
retractions,
so when
and
you
respiratory.
examine clinically by auscultation, air entry you check, and grunting. So it
Yes.
is considered to be a very comprehensive and it is more user friendly. Even a paramedical staff, like for nurses, can also do Silverman Anderson score may be difficult for them, and Downey score is easy. So here they have incorporated Downey score, and it has been already validated in preterm newborns also. So Downey score can be done in preterm, isn't it? What about intubated newborns at birth regarding need of surfactant?
Sorry, sir.
So when newborn is intubated, who is a preterm, so will you give surfactant?
Yes, sir.
Okay. So what do you have any FiO2 criteria for newborn on intubation? FiO2 of 21%. Will you intubate? Will you give surfactant?
Sir, FiO2 requirement of 30%
No.
indication for surfactant and peak.
Yes. So that this is the area of gray zone, isn't it? So sometimes they
Yes,
say
sir.
when baby is on CPAP, they have increased the FiO2 criteria to 40, and when baby is intubated, they are flexible to 30% FiO2. What about other surfactant administration guidelines, which may be a protective for the lung of the newborn?
Please.
Yes, Dhoni, you can answer.
Lisa, less invasive surfactant administration. Then
Okay.
MIST, which is minimal invasive surfactant administration.
Right. So both
There
are
are
most. Yeah, go ahead, please.
Ensure.
Okay, yes. So ensure may have better protection to the lungs. Any mechanism? How Lisa has less damage?
The less positive pressure is applied, and no and the catheter which we use to administer the surfactant, it is very thin, so there are less chances
Yes.
of inflammation to the vocal cords and the trachea.
Right. So we don't insert endotracheal tube in the trachea in Lisa, isn't it? So there will be less airway trauma by thin catheter, and we continue CPAP while we are giving surfactant in a small continuous flow, isn't it?
Yes.
So we don't provide high ventilation to deliver surfactant in such circumstances. So direct trauma to the lung is reduced, and that reduces the need of intubation and mechanical ventilation. And that is how it helps in reducing ventilator-induced lung injury, and it has been shown that it is protective for the lung. So what are the lung protective ventilation strategies? Already we have discussed, isn't it? So I want to elaborate in more about lung protective bundle. Can you give answer of this question? What is lung protective bundle?
Gentle ventilation, then early
So that is
surfactant.
one. Lung protective ventilation is one of the part of this lung protective bundle. What is another bundle which we can use to reduce respiratory morbidities?
Surfactant administration, low tidal volumes.
Okay, that is lung protective ventilation. Low tidal volume, that is volume ventilation, isn't it?
Yes.
CPAP we will use, surfactant we will use early, Insure, Lisa, right? Optimum PEEP. We may use
Yes, sir.
capnography. We may use HFOV, already answered. Some of the students have already answered. HFOV can be also used, and targeting SpO2 90 to 95%. They're all the kind of lung protective ventilation. Another is WEP bundle, isn't it? So what is WEP bundle?
Prevention of ventilation ventilator associated pneumonia.
Okay, so when will you suspect a child as ventilator associated pneumonia?
Baby is intubated for a long time, more than 7 days.
Okay, so whenever there are fresh new patches on lungs, isn't it? Increased need
Yes.
of
The new
ventilation.
opacities.
Yes, new opacities, increased patches on the lungs, increased need of surfactant, increased need of ventilation. These are the early clinical markers of WEP. So what do we include in WEP bundle? So whenever any newborn who you care who is intubated, what actions you will measure, take?
Sir, frequent chest physiotherapy and sectioning, sir, positioning of the babies.
Okay, so what
Hand
about
wash.
positioning?
Sorry, sir.
Yeah, so we do good hand hygiene. Okay, so whenever we want to touch a baby, who is already intubated, ventilated. Good hand hygiene compliance is very important, isn't it? Whenever you want to do endotracheal suction, gentle suction, isn't it? And
Yes.
you wear sterile gloves, sterile new disposable catheter to suction. Avoid high pressure during suctioning, isn't it? Head
Yes.
elevation around 30°. Would avoid aspiration. Then oral care, you may use the normal saline to clean the oral cavity. You do not change circuit frequently. Only when it is visibly soiled, you will change. And always check for extubation readiness, isn't it? So whenever you take rounds in the NICU, you see for whether baby really needs intubated and keep mechanically ventilated or not. So whenever in rounds, you decide for extubation readiness. So these are some of the components of web bundle. And probably if you take care of this, probably infection pneumonia would also be reduced and will help a newborn. Tushar sir, do you have any questions?
No, excellent.
There's one question in the chat box. Junaid has asked a question. What about mixing steroids with surfactant? What are the recent advances? So I think he's talking about budesonide with surfactant.
Oh, okay.
I think so it has a role in reducing bronchopulmonary dysplasia, especially when it was extreme preterms and when there are increased respiratory support is needed. Budesonide mixed with surfactant helps in reducing bronchopulmonary dysplasia, but it needs further evidence to support the effect.
Okay. I think there was an initial trial from Taiwan which showed promising results, but the more recent PLUS trial from Australia has not shown any benefit of the budesonide with surfactant. So as of now, it is not advisable. There are certain more trials that are ongoing, and we'll have to wait for the results of those. So at the moment, not advised to mix budesonide with surfactant. Tushar sir, you wanted to add something?
Oh, no. I was just checking the comments in the chat box. I didn't open it. But I think perfect. Still, it requires more studies because currently the evidence doesn't support it to use it because of rightly pointed out the Australian trial again. So we require more studies to recommend use of budesonide with surfactant. So at this point in time, no budesonide to be added in surfactant, isn't it? Are there any more questions? Mixing steroids? There's there.
I think most of the questions are covered as well. I
Covered.
couldn't see
Okay.
any new question in the chat box.
Right.
I think we're already about 25 minutes over time.
All right.
So
Great. So I think
it was a great learning session. Thank you very much to both our presenters and both the experts. Thank you for your insightful questions and very interactive discussions. Gunjana,
Thank you, sir.
I think
So thank
we've
you,
come to
Dr.
the end.
Yeah, sir. Yes, sir. Thank you, Amit, sir. And thank you, Dipin, sir. Thank you, Tushar, sir. And both the presenters, Dhwani and Sachin. It was a great discussion. And it lasted quite long. And I hope we still had around 100 participants, which are still there, active and interacting with the faculty. It's a great achievement. And thank you so much, sir, for being a part of this Noel session and giving your insight and a lot of inputs to the all the fellows. I hope it's going to be a really beneficial session for all the fellows. Thank you so much, sir, and thank you everyone for joining.
thank you, everybody.
Thank you.
Good night.
Good night. Thank you.
Thank you, sir. Thank you, ma'am.
Thank you so much. Thank you.